This is The Rounds Table. All right, welcome back. New podcast episode. I am flying solo, and I will be covering Tirzepatide for obesity treatment and diabetes prevention, the long-term results of the SURMOUNT-1 trial, published in New England in print March of 2025. All right, setting the stage first. Google/ChatGPT has informed me that there are 1 billion people globally who have obesity, and 2/3 have prediabetes. A reminder, prediabetes is generally defined as an individual who has a hemoglobin A1C of 5.7% to 6.4%. I've sometimes worried that prediabetes feels a little bit made up, a little bit created by drug companies, but I'm having second thoughts, and I think you'll see why by the end of this study. So another reminder is that 70% of adults with prediabetes will eventually develop type 2 diabetes. For adults with obesity, what prevents type 2 diabetes? Well, lifestyle modifications and interventions, of course, can work, but I think in practice, it can be hard for those to be sustained. Bariatric surgery, of course, can cure adults with obesity of their diabetes, but only a small subset of all individuals with obesity will go on to have bariatric surgery. And in the past few years, we've had some secondary analyses of randomized trials of GLP-1s like liraglutide and semaglutide that suggest, hey, maybe those drugs might help. And here, really, what we're curious about in this study is, what about a combined GIP-GLP-1? It's an alphabet soup, but GIP, that's glucose-dependent insulinotropic polypeptide, and glucagon-like peptide 1. So that's where you get the GIP and GLP-1. The drug you're probably most familiar with is Tirzepatide. I think of it as semaglutide's younger, stronger, more impressive brother or sister. It was approved and has been approved by the FDA, by the EMA for both obesity and type 2 diabetes. And if we rewind the clock, the SURMOUNT-1 trial showed us that for adults who have obesity and who are randomized to Tirzepatide, they experience a 20% weight loss. That's pretty incredible. And a 0.5% reduction in hemoglobin A1C. And here, the authors are reporting the 3-year results for that trial, and in particular, interested in the subpopulation of those with prediabetes. So the design of this study, as mentioned, it's a sub-study from SURMOUNT-1. SURMOUNT-1 was industry-sponsored, double-blind, placebo-controlled trial of Tirzepatide in persons with obesity. The key inclusion, a BMI of 30 and above, or 27 and above, and they had an obesity-related complication. As I've already stated, this was a sub-study that only included those who also had prediabetes. Some key exclusion: if they had type 2 diabetes at baseline, prior pancreatitis, a history of MEN2, a family history of personal history of medullary thyroid cancer, a history of depression, or prior suicide attempt. The intervention here was Tirzepatide at one of 3 doses: 5 milligrams, 10 milligrams, or 15 milligrams, and that's injected weekly. Patients were treated for 176 weeks, and then this was followed by a 17-week off-treatment period, which I actually really like, because many patients ask me, hey doc, if I stop the medication, what happens? The comparator was placebo. The outcomes here, so one was a percentage change in body weight by week 176, and another outcome was onset of type 2 diabetes by week 176. So what did they find? Well, they ran this study from 2019 to 2024. Overall, 2,500 patients were randomized. 41% had prediabetes at baseline, so approximately 1,000 patients, and those are the individuals included in the sub-study. How many patients completed the trial? Only 66% made it through week 193, and adherence overall to drug or placebo was approximately 64%. Average age of included patients was 48, 63% were female, 73% were white. Average BMI was 39, and average A1C at baseline was 5.8%. In terms of weight loss, what did they observe? Well, by week 176, for adults who received Tirzepatide 15 milligrams once a week, they had a 24% reduction in their body weight. It's impossible not to editorialize how impressive that is. At the 10 milligram dose, a 22% reduction in weight. At the 5 milligram dose, a 16% reduction in weight. So clearly, you see this dose response. And in the placebo group, they lost approximately 2% of their body weight. Now remember, they also had that 17-week off treatment period to see what happens when you stop it. In general, patients gained back some of the weight, but not all of the weight. Of course, it's only by week 17, so who knows what might be observed if it's stopped indefinitely. But just as a context, for adults who received tirzepatide 15 milligrams weekly, reminder, they saw a 24% reduction in their weight. And what happened after the 17-week period where they stopped the drug, the reduction in weight was lower, of course, and they had lost, approximately 18% of the weight. So said differently, they gained back 6% of the weight. Now, for the outcome that I'm really interested in for onset of type 2 diabetes, in the tirzepatide group, 1% went on to develop diabetes. In the placebo group, 13%. That's a hazard ratio of 0.07. I've never seen a hazard ratio that low in my life in a clinical trial. Please let me know if I'm wrong. And there's an example of one that was as impressive. Absolute risk reduction at 12% absolute risk reduction, which is pretty remarkable. In terms of adverse events, serious adverse events occurred in 13% of those who got tirzepatide and 12% of those who got placebo. The most common side effect with tirzepatide is GI, and that's unsurprising. They also observed higher rates of gallbladder-related disease is what they referred to it as, but really it was like gallstones and a few cases of cholecystitis with tirzepatide. There was also higher rates of hypoglycemia with tirzepatide, which that is something that surprised me and is important for us to be aware of. So those are the results. That was the study. Putting it into context, my 2 cents, my 10 cents, this is really impressive. It is really impressive to see the long-term results for these medications. Degree of weight loss is amazing, right? Like, let's just say it as it is. These are the results that you see with gastric bypass, okay? So the idea that a medication could approach the level of weight loss with a surgery is remarkable. I also think having these long-term data are incredibly helpful for how we inform patients on the benefits and the risks. It is, humbling, maybe sad to see that even in a clinical trial where you're exerting all of your energy to keep patients on these medications, that by the 3-year mark, adherence is only 66%. So we should be very much mindful of that to set expectations. And I would hazard a guess that in the real world, adherence will be lower. It was also nice that they had this period of what happens when you stop the drug, because as I've alluded to, that's a common question that patients have. They ask, hey, will I gain all of the weight back? And truth be told, more often that's conversations I'm having related to semaglutide. Tirzepatide isn't a drug that I've prescribed yet, but I think that will change soon. And I think we can also counsel patients that in addition to this medication improving your weight, it markedly reduces your risk of developing type 2 diabetes. Okay, so what about the limitations? Every study has limitations. This is no exclusion. This was relatively small, and it was a secondary analysis of a trial. So sometimes this can be a bit of a fishing expedition, and it's really important that secondary analyses of trials, hopefully they get replicated elsewhere to confirm that this represents a real finding and not a spurious finding. I don't think this is a spurious finding, to be honest, but those are some of the caveats. This was an industry-sponsored trial. So we know that industry-sponsored trials, they're more prone to, positive spin on results, and we should take it with a grain of salt. But overall, I find these results really encouraging, and it's exciting to be a general internist these days. Very often when I'm caring for patients in hospital, usually it's because there's some bad diagnosis, right? They've newly been diagnosed with cancer. They're coming in with a COPD exacerbation. They're coming in with a heart failure exacerbation. And As internists, we don't always have the best of news to convey to patients. And that's why I find it exciting with drugs like Tirzepatide and semaglutide, that for many of the patients we care for, we have a good news story. Here's this medication for you, and it will lead to reductions in weight, potentially reduce your risk of heart attack, stroke, death from cardiovascular causes. Anyway, those are my 10 cents. Let me know what I got wrong, what you disagree with, and we'll wrap up in the next minute. A reminder, we have a new blog called Q Monthly. It's a monthly newsletter that succinctly summarizes 2, sometimes 3 trials from the past month. Usually there's like a headliner, some big trial in New England that you probably saw, as well as 1 or 2 hidden gems. Maybe it was published in a smaller journal, super relevant to internists and hospitalists, and we hope to surface these results to you to keep you up to date. Written by yours truly and edited by Katerina Zorcic, who's an outstanding second-year med student at Queen's. All right, that's it. Stay well, and see you next time.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.